like to request Dr. Siddhartha Shrama from PGI Chandigarh, very good friend of mine. So I love his talks. He's got a very beautiful way of presenting the talks. So it's over to you, Siddhartha.
Thank you, sir. Thank you for those kind words. And sir, if you can just confirm if you can see my screen.
Yeah, we can see your screen. Please carry on.
Okay. So good morning to all. And I will be talking to you about fractures of the talus. And this is how I've outlined my talk. So we will be looking at the anatomy, classification, pathomechanisms, management, outcomes, and complications. So the talus has a head, neck, body, a lateral process which articulates with the subtalar joint as well as the fibula, a posterior process which has two tubercles, the medial and the lateral, and the groove in between has the flexor hallucis longus. So this is the pertinent anatomy. And mind you, 70% of the surface is covered with articular cartilage. It forms three important articulations, as you know, the ankle joint, talonavicular joint, and the subtalar joint. Now, the blood supply is very important. It's also a very important examination and viva voce question. The most important supply to the talus, blood supply, comes from the posterior tibial artery, and this is by means of the deltoid artery and also through the artery of the tarsal canal. Now, please remember, in case of a displaced talus neck fracture, the deltoid artery may be the only remaining source of blood supply. The anterior tibial artery gives off the artery of the tarsal sinus, which anastomoses with the artery of the tarsal canal. The perforating peroneal artery, I would say, is the least important source of supply because it is so variable. So the talus develops from a primary ossification center, which is present before birth, and there is a secondary ossification center for the posterior process, which develops around 8 to 11 years of age. Now, there are three important anatomical variants that you should be aware of. The Steda's process is nothing but an elongation of the lateral tubercle of the posterior process. The os trigonum happens when the secondary ossification center that I told you of the posterior process does not fuse. Both of these conditions can lead to a posterior ankle impingement. Now, the os supratalaire is rare, but this is an accessory ossicle on the dorsal surface of the talar neck. Let's move on to the classification now. So loosely we classify this as central fractures, which is the neck and the body. All the other fractures, the head and the posterior process, form the peripheral fractures. Now, how do you differentiate between a talar neck and a talar body fracture? This is very important, and for this you have to know the Inoguchi criteria. So if you look at the lateral view of the ankle joint, this is the lateral process of talus. If the fracture line is anterior, now if the inferior part of the fracture line is anterior to the lateral process of talus, this is a talus neck fracture. If it is at the lateral process or posterior to the lateral process, this is a talar body fracture. Now, talus neck fractures were classified by Hawkins into three types, and a fourth type was added by Canale and Kelly. So type 1 fractures are undisplaced fractures. Type 2 are displaced fractures with subtalar joint dislocation or subluxation. Type 3 have, in addition to subtalar joint, the tibiotalar joint dislocation. And type 4, which is the Canale and Kelly variant, also have subtalar, tibiotalar, and talonavicular joint dislocation. So looking at the peripheral fractures now, the lateral process fractures are also known as the snowboarders fractures, may be caused by inversion or eversion. If these are small fragments, you excise them. If there are large fragments, you fix them. Posterior process fractures are caused by forced inversion. That is why they can sometimes resemble ankle sprains. Again, small fractures excise, large fractures fix. Now let's look at the pathomechanisms. So the typical mechanism of a talus neck fracture as described by Coulthard was the aviator's fracture. The talus body gets wedged in dorsiflexion between the plafond and the calcaneus, and the continuing dorsiflexion force breaks off the talus neck. Now, mind you, this can also happen because of an inversion strain when you have medial comminution and lateral tensile force. On the other hand, talus body fractures most of the time occur from axial loading. The talus body is forced against the plafond and it results in varying degrees of comminution. Now let's look at the management. So the workup has already been described in good detail by Dr. Girish. Here, one of the important views is the Canale view, and you need to flex the knee and hip to 90 degrees. The beam should be angled 75 degrees cephalad, and the leg should be rotated 15 degrees inward so that the lateral border of foot is off the ground. In this position, as you can see here, you will be able to visualize the talus neck. A CT scan is essential and mandatory not only to know what is your fracture configuration, but also to identify the comminution and to plan your approaches. So timing of surgery, as in all foot and ankle cases, if there is swelling, you may have to wait. But remember, if the body is extruded, this puts pressure on the skin. And if there is a subtalar or other joint dislocation, you have to reduce this early. You may fix this later. Now again, please remember, for all talus neck fractures, dual approaches are the standard of care because they give you better assessment of the fracture reduction. Now for a neck fracture, the standard of care is anteromedial with an anterolateral approach. For a body fracture, you have to visualize the intra-articular part, which is the talus body or the dome. For that, you have to do a medial malleolus osteotomy. For the very rare posterior talus fracture variants, you may do a posterolateral or posteromedial approach. So the anteromedial approach is a straightforward one, runs from the tip of the medial malleolus to the first ray. The important structure here is the saphenous vein. Split the capsule and you're directly onto the neck. Remember to preserve the deltoid ligament in this case. The anterolateral approach runs from the tip of fibula to the fourth metatarsal. You can split or elevate the extensor digitorum brevis, and you can see the subtalar joint, clear out the comminution fragments, and you have a good access to the anterolateral neck and body. Now, medial malleolus osteotomy, you should always do it at the level of the shoulder of the medial malleolus. Pre-drill your osteotomy so that you can fix the swell later on, and this hinges on the intact deltoid ligament, preserves the blood supply to the talus. So for non-comminuted talus neck fractures, you can do a closed reduction, percutaneous pinning, use compression screws, and screws are always inserted perpendicular to the fracture line. For displaced talus neck fractures, remember that most of the times comminution is medial. So here in this case, for example, we used a medial graft and a medial plate. You may also use a combination of K-wires or positional screws, which are 3.5 millimeters cortical screws. On the intact lateral side, you can use compression screws. So for talus body fractures, again, you have to use a combination of screws and plates depending upon the fracture pattern. So let's look at the outcomes and complications. The best outcomes are there for type 1 and type 2 Hawkins fractures. And remember, whenever there are complications, it results in poor outcomes. The common complications are AVN, arthrosis, malunion, and infection. Now remember this chart, memorize it by heart because this is so commonly asked in the examination. As the degree of displaced talus neck fracture increases, the Hawkins grade, the rate of AVN also increases. What is the Hawkins sign? This is a very favorite examination question. This is a subchondral lucency seen at 6 to 8 weeks. It happens because of an increasing vascularity. Remember that if you have a positive Hawkins sign, if you see this subchondral lucency, there are very less chances of AVN. On the other hand, a negative Hawkins sign is predictive of avascular necrosis. Now, what do you do when you have an AVN? So for an early AVN, you protect the ankle, protect it in a non-weight bearing offloading ankle foot orthosis. As you can see here, extracorporeal shock wave therapy is an up and coming modality, but still needs to be established. If there is a central if there is a AVN but without a central collapse, you can consider an option like core decompression with or without grafting. And if there is an established AVN with collapse, you have to consider fusion procedures. Now, this is a beautifully done Blair's procedure by Professor Dhillon. And please remember that novel arthroplasty procedures are done here. A standard total ankle arthroplasty would probably not work in this condition. So you have to do something like a total talar replacement. Arthrosis, the most common one is subtalar arthrosis. Tibiotalar arthrosis, yes, sir. Tibiotalar arthrosis is seen in up to 18% of the cases. Now, mind you, not all arthrosis is symptomatic. If your patient has pain and restriction of motion, you would do a fusion. Malunion is also an underdiagnosed complication. Now, a malunion of a talar neck presents with a hindfoot varus. There is collapse and shortening of the medial part of the talus as well as a medial tilt of the heel. So, a treatment, if the ankle joint is congruent, would be to do a medial opening wedge osteotomy of the talus with or without arthrodesis of the subtalar joint. Infection is seen mostly in open fractures. Therefore, a meticulous debrima and antibiotic therapy is a must to prevent infection. So people, the essential revision points that I would say when you go for your exams or your viva, please remember to revise the blood supply of the talus. Remember to read up on the Hawkins classification and its relationship to AVN. This is very commonly asked. Please remember when you are asked about the approaches, always dual approach, because you have a very good control of the fracture reduction, especially the varus and the rotation. You always look out for the medial comminution. Remember to answer in terms of bone graft, medial plates, or positional screws on the medial side, and Hawkins sign, of course. So thank you. That will be all.
Uh, so thank you very much for the wonderful talk, Siddhartha. It was really great talk, I must say.